So good morning, everyone, and welcome to this webinar. So my name's Mike Gibney, and I'm the Director of Workforce and Innovation at the Walton Centre here in Liverpool, which is obviously an NHS trust. I'm going to kick this off just by sort of saying, obviously, it's been an extraordinary time in terms of healthcare and patient care across the country, across the world. But obviously, we're going to focus on our local area. We're going to focus on Liverpool. So the background really has been that if you go back 12, 13, 14 weeks, if you think about what was happening in Italy, there was a period when people were stripping the shelves. There was a period where, we certainly didn't know, pardon me, in this trust that we were going to have enough protective equipment, we were going to have enough hand sanitizer, all sorts of challenges that we'd not faced before were coming our way. In response to that, we suspended all our business as usual. So this trust, we virtually cleared out 80% of our patients to make room to respond to the pandemic. We had at that stage unlimited government resources to focus upon COVID, and we've responded. And the curve that was so often talked about at the Downing Street press conferences was flattened, and we got through that, and we did that, and gradually over time local supply chains have picked up, which I'll come back to. But that's left us in a place where we ended up quite isolated. Every area did. We were dependent upon our local businesses to support us for food, for gin companies, producing hand sanitizer. I know there was quite amusing stories last week because some of them are 90% alcohol and spontaneously combusting in front of cars on very hot days. But so there is some value to ISO standards. There was certainly we've had local people make scrubs for staff here. We've used local companies to improvise and make 3D printed visors and things like that. So we went through this kind of incredible breaking down of barriers, and now we're at the point where the first curve is down. There may be a second wave, there may not, but clearly we're in a different world where we've now got economic recession's probably not the fair word. I'm going to quote the chief exec of Liverpool Council, who was saying in the short term, so I emphasize the short term, this could be a recession coming our way. That is how challenging this is. And then of course we've got an almost complete suspension of business as usual that we've got to pick up on. And obviously with our two guests this morning, we'll be looking particularly at cancer, which is of course almost a generic condition that affects, that there is no kind of unique element. It affects all parts of the body. So with that said, you'll have seen the publicity. So it's Mike Moran and Karol Sikora. So I was going to start by getting Mike and then Karol to introduce themselves, and then they'll come back to me and I'll just set out what the ground we're looking to cover. Should you feel at any point that either any one of the three of us was waffling and going off in some direction that you thought was unhelpful, there's a Q&A box that you can put your questions into, and some of our colleagues are going to be collating that and pulling out the themes and pulling us back on track. Okay, so with that said, Mike, would you kind of like to set the scene? Who are you and why on earth are you here?
Well, Mike, thank you very much, and I wish I was in Liverpool. Now we're champions of England again, rightly where we should be. That's the football team. But I'm Mike Moran. I'm Chief Executive and founder of Rutherford Health. And Rutherford Health is a PLC, a company that was listed on the London Exchange last year. We were formed in 2015. We've raised over £300 million in equity to build a network of cancer centres, and those centres are operational in Newport, South Wales, Northumberland and Thames Valley. And of course, we've just started the commissioning process and CQC in the flagship centre in Liverpool, which was a 40 million investment in the city of Liverpool. In addition to that, we've recently announced that we're building a network of diagnostic centres, and that will provide the funnel, if you like, for our cancer centres. We're The key now to good cancer diagnosis is early diagnostics and making sure that we can link in, get the diagnostics right early, and then hopefully get those patients through into cancer treatments.
Okay, thank you, Mike. And that's very helpful. And I think the early diagnostics is a theme we'll be returning to. So let's actually turn to the expert on cancer. So, Karol, do you want to reveal who you are to colleagues?
Thank you very much, Mike. I'm Karol Sikora. I've been an oncology consultant in the NHS for over 40 years now, so I'm a very old man. But I have been around the houses in cancer, and as chairman of the Department of Imperial Healthcare for Hammersmith, Charing Cross, St Mary's for about 20 years, and the budget holder, which is not a nice thing to be at a time when costs are escalating in cancer. So the current situation with COVID and cancer is that the minute it happened, the NHS in March went into COVID mode, and it's like a battleship. It turned round in the sea, and it did it fantastically well. It built the capacity, so when the predicted crisis hit, it actually hit on April the 8th. It was meant to hit on April the 13th, but it came 5 days before. That's pretty good epidemiology to predict the maximum use of critical care facilities. When it hit, there were ample facilities with one or two little patches of overuse in northwest London. But other than that, it was very smooth, and it went rapidly down after that. The battleship turned into COVID mode. Everybody changed. Oncologists were staffing intensive care units. Cancer patients were still being seen if they had to. They're prioritized into bands of risk. Now the battleship has to turn back. And unfortunately, because we all know the NHS is such a large apparatus, it's turning back very slowly. And that's the problem we've got. Data released by NHS England only last week suggested that the overall admissions were down 85% into hospitals now. The 2-week wait, which is the way about a quarter of cancer patients present, where the GP can request a patient to go because he or she thinks they've got cancer, they can be seen within 2 weeks by a consultant. They're down 65%. Breast referrals, which is the way in for breast cancer, are down by 78%. And perhaps worst of all, endoscopy, that's putting a tube in the orifice either through the mouth or up the bottom to detect what's going on if someone's suspected of having stomach or colorectal cancer. That's just disappeared. And even as of June the 7th, was down to only 10% of what it should be. So that's pretty dramatic evidence that the ship is still leaning on the wrong course. COVID's gone in terms of intensive care unit use, in terms of hospital admission, in terms of 111 calls for suspicious symptoms of COVID. And yet, what we see is a system that's not geared back yet. Now, what's that mean for cancer? Cancer doesn't take holidays over Easter or because of pandemics. It's coming. And the patients out there are not being diagnosed because we know that, because the number of biopsies are at rock bottom. Even still, even though we're entering July tomorrow, we are still way below 30% of the number of biopsies last week that should be carried out for cancer. Cancer, unlike COVID, there are no peaks and troughs, there's no second wave, it's just a continuous wave. And it's 30,000 a year, that's 1,000 patients a day. It's the simplest way to look at it. 1,000 people should be coming forward each day with cancer, and they're not. We know they're not, still not, 3 months on. Why not? Because of COVID, that's all it is. Because it's a whole system needs to get started. It's the diagnostic pathway for endoscopy, the diagnostic pathway for MR. We know the waiting times for the waiting list for magnetic resonance imaging, which is one of the key diagnostics for cancer, is up by 1,200%. And there are several trusts where more than 5,000 people are on a waiting list for either a CT or an MR scan, which is the way into a cancer diagnosis. So we know the problem. That's the first problem, getting cancer diagnosed. The second problem is that it's all going to come at once because we're just stacking up the cancers. So the April cancers, the May cancers, the June cancers are still not diagnosed. And at the same time, we're going to have the July cancers coming next month, 30,000 people trundling through each month with cancer. So it's a huge logistic problem. So there's, with NHS England and the private sector, looking at ways that we can all come together to collaborate in moving the whole thing forward when the crisis hits. It is like a tsunami. It's exactly pandemic tsunami. It's just a more insidious one. You can't see it as well. You can't do a quick test for cancer. It's much more complex. How will it affect our patients? That depends. So it depends on the type of cancer. It depends on the stage of the cancer. For every cancer, there's a stage. Stage 1 implies it's confined to an organ. Stage 4, it's spread right around the body. And there are various definitions of each individual cancer type based on its likely routes of spread. So what we're going to see is migration of the stage upwards. So people presenting, say, in March with symptoms that have not been sorted out until now, maybe next week, they're likely to have moved from stage 1 to at least stage 2, maybe even stage 3 during that delay. And that's going to mean the outlook is going to be poorer for them. And not only that, the treatment may be more complex. It may not just be surgery, it may be radiotherapy, it may be chemotherapy in addition to that. So we have to be ready for that wave of cancer patients that's going to hit the shores. I suspect later than we think. I think it's going to be August or September before it really comes. So what's the plan? So we've come up, Mike and I have obviously worked together for the last 5 years now closely, and we have come up with a plan which to look at how the independent sector can collaborate with the public sector, with the NHS, in making sure as many people as possible can be treated as quickly as possible to get us out of this bottleneck. If we don't do something, it could be that more cancer patients will die than have ever died of COVID. We know the COVID death rate as of last week has come down to almost zero. There are significant numbers still affected from earlier on, but it's much, much less than it was at some time, a few weeks ago. So we're getting out of that. We've got to deal with cancer. So the 5-point plan is quite simple. First of all, we need information. We need to really sort out the biopsy rate on a week-by-week basis to know when the peak's coming. The second thing is we've got to create COVID-free zones. We've got to, our centres, we take people's temperatures, everybody that goes through the door. We've got to really protect the environment for cancer treatment. The independent sector, the third thing, use it. There are 26 private radiotherapy facilities scattered around the UK. A lot of people think it's only in London. It's not. There are 26 centres, including our own, and there are 65 places you can get chemotherapy. And then we have to sort of look at the strategies to reduce the footfall in cancer centres, look at regimens that reduce the number of fractions of radiotherapy where it's safe to do so, and also convert intravenous chemotherapy into oral chemotherapy. And then the fifth strategy, obvious one, extend the working day when the crisis comes through. Now's the time for diagnostics to do that. You know, if you can only do 10 MR scans a day, now's the time to find a mechanism to do 20. It's possible. It may involve working differently, using different staff that may be not so experienced to get patient flow so that the experienced radiographers can actually do the business end of the magnetic resonance scanning, the positioning of the patient, and using other staff to move the patients on their journey through the department. Evenings, weekends, volunteers and paid staff, essential to get this. If we approached it exactly like we approached COVID, we'd win through. I mean, if we can do it for that, surely we can do it for cancer. And the independent sector, including Rutherford's obviously standing there, ready to do it. And all the bureaucracy behind that, the governance, the business side, the tariffs, that's all been sorted out. So we are ready to go. The last thing, and I'll stop, is just fighting the fear factor. One of the reasons it's not the NHS's fault, it's not the system's fault, it's that people are too frightened to go to their GP. And so we're stuck. If people won't come to their GP, we can't do anything. We can't identify cancer patients. So that's a pretty important key thing.
Okay, thank you. That was quite a powerful opening statement, Karol. I think, thank you for that. I think I'd say you're right about the fear, but there's fear. It's quite interesting, just as somebody who's in a hospital, that people, I've been quite surprised at the people who've actually been almost spooked by COVID in a way that perhaps I've not seen before. And of course, it's had a knock-on effect in things like social care, where there's, certainly the last time I looked, there was 1,600 beds free in Liverpool in social care because it had a reputation for being a COVID zone, which kind of leads us nicely into, Mike, I didn't know if you wanted to add any more to the strategy, but perhaps you could talk about some of the practicalities for us, really. I was thinking particularly about how, because how we can ensure that going forward, COVID hasn't gone away. How are you going to ensure that your centres, maybe talk a bit more about the strategy, and so in real sense, how are you going to ensure that you're not going to hopefully have COVID patients with COVID in your environment, and what you're going to do if that does happen, really. So, Mike, do you want to?
Yeah, thank you, Mike. I think at the outset of this pandemic, we established a operations room in Hereford, and we put in some of the key functions around the business so we could think clearly and act deliberately. And that was important to us. And what we recognized quite quickly is we had an issue around confidence of our staff entering the centres, but also of patients. And we needed to have a very visible barrier there, which also integrated into information and comfort for the patient. So we looked at what we needed to do to put in place, and we eventually realized that actually the military offer some real expertise in this area. If we think of COVID as, CBRN, chemical, biological, radiological, and nuclear, and the B in that is the biological. And what we recognized was actually we needed to recruit ex-military CBRN experts to sit in front of our reception staff and offer, we call them patient coordinators, and we offer temperature testing and a questionnaire. So they ask key questions around family history and travel history, and we do the temperature check. And we graded them in a traffic light system, green, amber, and red. If they were green, they can go about their business into the centre. Amber, which could have alerted on one of the questions, they may have a temperature that's in the zone that we needed to be in, but they maybe have just travelled or just returned from travel. And then we would escort them with somebody with PPE into an area. And if they were red, they were definitely either positive COVID, and we would rearrange their treatment. So our plan from the outset was to maintain a COVID-free environment and keep COVID out of the threshold. And that's worked very well. Now, going forward, that worked for us. We're fully operational. We treated a number of COVID positive patients during that time. And it was really down to the confidence level. We managed to retain 98.5% of our staff into our centres. We had a number of staff who were shielding, but we had high staff buy-in to the service. And that was around that confidence that the patient coordinators delivered. Going forward now, we're intent on retaining the patient coordinators at the front door, and we intend to make sure that all of our appointments are planned. And if we do have any COVID positive patients or any high risk patients, we bring them to the end of the working day where we can do a full deep clean. So, we're about to commission and open our fourth centre in Liverpool, and it's important that from day one that retains its COVID-free status, and we can offer chemotherapy and imaging treatments from the first week in July.
Okay, thank you, Mike. And I think I'd add just that. So I think we're all saying, unless Karol will probably be the wisest guesser on that, the subject about when we're going to get a vaccine, but clearly the way that we shop, we work, we eat, we live is going to be impacted by this for quite some time, which kind of leads me into the bit. So Karol, you've kind of teed up by saying, look, so we recognise we stopped everything, we focused everything on tackling COVID, it's been successful. However, now we've got there's been a lot of unintended consequences in the way that we've done it. I wondered if you could say something about how on earth we're going to try and coordinate the kind of the prioritisation of patients, and just and I appreciate you're not the oracle, but we are going to have to find some way of everybody rowing in the right direction in an area like Merseyside. It's still going to be one of the biggest challenges we faced, and we've not necessarily had a proven track record in covering ourselves in glory every time.
So I think the key thing is to get the information. For example, and it's going to have to be locally. So if you take Liverpool, you have all the information about where your diagnostic facilities are, both NHS and private, where you have treatment facilities, radiotherapy, chemotherapy. And then you've got to coordinate the whole thing and prioritize the patients. It all has to be done at a local level by the existing staff. I think as long as they're given the okay to look at imaginative solutions, that's the most important thing. And they are being given the okay by NHS England. And for once, it's not funding, it's not money. All the business side has been agreed. It's just a matter of going forward. What disappoints me, and it's nobody's fault, is that there is no crisis at the moment. There's no crisis at all because it's a hidden diagnostic problem. It's locked into the diagnostic phase. So we're not identifying the cancer patients, so they're not coming forward, which means you don't see any crisis. And there's plenty of scope within NHS departments to treat those patients that come forward. But that could well change by August, when we will see people coming through it, and there'll be people that will need more chemotherapy and more radiotherapy. So that's the key, Mike, is to recognise it and deal with it locally. We, Rutherford, are opening up our doors, hopefully, for chemotherapy over the next 2 weeks. And that would certainly contribute to any shortage of capacity for chemotherapy in central Liverpool. And there are other places one can do that too. So that's what I'd like to see, a coordination locally.
Okay. If I could just follow up on that, because I think something about, so I obviously in our hospital, being completely non-patient facing, I know that, so some patients who perhaps weren't getting treatment, but are very, very assertive, have come to the attention of people who book appointments and things, and we sorted them out. But there's this kind of group of people that often are reluctant to come anyway. It's not something pleasant to face if you think you've got symptoms. So is there a kind of a role maybe at some point? Do we need to switch this around, and or do we need some kind of publicity campaign or something? Because there seems to be the people who are good at understanding the system they're the first people in our clinics as we're kind of uncoiling from COVID. But it is, as you say, there'll be lots of people out there who perhaps, cancer's a tough one anyway. We know people often leave it long before they come and share the symptoms. Is there some kind of, are you aware of any plans, or is there a need for some kind of new way of kind of communicating and telling people?
I think there is. Matt Hancock stood up and said that at one of the meetings. Everybody's trying to reassure people to come forward. And the way into the system, as we all know, is through the GP. It doesn't mean going to the GP. A phone call may be all you have to do. If you're still worried, get a relative to make the phone call, or get a friend or a neighbor to make the phone call. Everything is possible now. I think the sad thing for people on cancer, you're quite right, it's an emotional journey to go on chemotherapy or radiotherapy, living with the uncertainty. And then on top of that, you've got the corona uncertainty of whether the treatment will be changed, whether it will actually occur. The saddest thing I've dealt with over the last 3 months are several patients, not of mine necessarily, who've received an email, a rather blunt email in some cases, from a leading cancer centre, not one I've ever worked at, but somewhere in West London, telling them their chemotherapy has been stopped because of the COVID crisis. Just stopped like that. Right. And one of my colleagues, who was actually a physician, a very well-known gastroenterologist, was so upset by this. He just went to pieces. And I said, well, why not just contact them? Why not just phone up and say, you're really a bit alarmed that they're stopping the chemo. You understood it was important. You're now on cycle 3 and you were going to have 6 cycles. So he phoned up and lo and behold, the next week he's back having chemotherapy. I mean, the trouble is it's a situation where no one really knows the rules. And if you make a fuss, it's easier to let you continue. And so you're right, we've got to look after the people that don't make a fuss. And that's the difficulty at the moment. The people that don't say anything, they may be older, they may be shy, they may be frightened completely. So getting them back in is so important.
Okay, thank you.
I think also, Mike, we were a lone voice at the start of COVID, and we ran a Twitter campaign around making sure that people do report, because we could see this happening months ago, making sure that people do report to the GPs. And a lot of GPs couldn't see anybody at the time. So there was this cycle of frustration. And, you know, an old saying that I always use is cancer's quick, bureaucracy slow. And I think the key thing now is we have to break down some of these barriers that traditionally exist. We have to take politics out of healthcare, and we have to make sure that we remove as many barriers. So there's almost a seamless integration between the NHS and the private sector while this crisis exists, and it can go back to a default setting later. But we also have to recognize and remember that the backdrop of this is we have some of the worst cancer survivorship rates in developed Europe prior to COVID. COVID has just added to that crisis even further. And unless we do something different, and my grandmother would always say to me, if you always do what you've always done, you'll always get what you've always got. We need to do something different. And that something different is about a better seamless pathway, whether it's delivered by the NHS or the private sector, as long as it's free at the point of use and there's an agreed tariff that is acceptable to both organisations. You know, we've invested over £300 million into our network, and we're more than happy to treat NHS patients. We already do on agreed tariffs. We obviously treat private medically insured and self-pay patients as well. But there's a seamless system there, and we don't see cancer walking in, we don't see a category of patient walking into our centres. We see people first and the disease second. And I think that's what we need to be able to do, is just really unlock the bureaucracy around access to the independent sector.
So Mike, I particularly was keen to, because Karol took us through the kind of strategic approach, but there's a real thing really about the kind of final stage was really about almost ramping up the capacity to cope with this, and it's quite challenging. And what I'd say is, just from an NHS perspective, not a personal perspective, but from an NHS perspective, you know, so I've had quite a good COVID because I've been in an office, and I also look after charity and I've been doing kind of, you know, certain things. People who've been on the COVID wards are knackered, and many of them are, as Karol said, you know, we've taken, so in the Walton Centre, we've taken neurosurgeons and spinal surgeons and oncologists and put them down on the wards. And that group of staff have had a pretty long go at it, really, and so you've got this kind of almost challenge. And I appreciate you're not a miracle worker, Mike, but there's something about how on earth do we, so what happens even if there's a second wave, there's this big gap in the middle where you know, as Karol's saying, there isn't really a crisis at the moment, but what we've got is some very tired staff, certainly in the NHS, where they've been full on, and somehow we've got to look at improving capacity, you know, perhaps weekend work, things like that, I think Karol mentioned earlier. So I wonder if you've got thoughts on how on earth you pull that one out of the bag.
Yeah, well, I go back to one of my early statements. It's about thinking clearly and acting deliberately, and it's about making sure that you can plan for the outcome. And you know, actually have a military background, so I was in the army for 20 years, and I'm relatively new to business. I think this is my 20th year or 19th year in business now, so I'm still learning. But one of the things that I have learned about it is, in any crisis, you have to plan at the start of that crisis for when you come out of the crisis. It was the same in 2008. So we have thought about the recovery phase post-COVID. And in any crisis, there are 6 things that you need to do. And that's to invest in your business, to upskill your staff, use that opportunity to upskill your staff while you can, collaborate, innovate, look at enterprise right across your business, and also competition. How can you work better with your competitors to be able to be more successful when you come out of the other end? So for me, it's those 6 disciplines that we've put in, and you know, anybody who follows our business will see through some of the announcements in terms of the investment and the upskilling of our staff and some of the collaboration. During this time, we've signed 3 NHS contracts for services in England and in Wales. And we've worked with some of our competitors to make sure that together we can contribute to the cancer crisis that's looming. So, you know, there's no substitute for planning. And you have to remember, no plan survives contact with the enemy, but it's actually going through the planning discipline, which is really important.
So I suppose really, if I throw that further over than to Karol, really, which is the question that kind of emerges is kind of, you know, so you've both mentioned bureaucracy. I'm not going to, you know, the NHS is the, you know, depending on how you know, the NHS in England is the 5th largest organisation in the world. You can add in other bits and it becomes the 4th. So maybe, Karol, you could say something about where your optimism levels are in terms of us really, you know, collaborating, because we're really, you're not even just talking public-private sector, we're talking, you know, the independent sector, third sector, you know, social care's got a big role. That's kind of heavily, it's a combination of public and private. I wonder if you could say something about where you're currently at as a social commentator.
Yeah, thank you. I mean, the Twitter account, as Mike mentioned, has been fascinating. It was purely set up to warn that cancer is going to be a problem in all this, and both cancer and heart disease, and to a certain extent mental health, issues that won't go away, and they just accumulate. And if you don't deal with them, they get worse, all 3 of those things. So, and the Twitter account has been good as a public health messenger in many ways. So it's quite pleasing to see. Now and again, there are some rather, the sort of people that write on lavatory walls come onto it and say a few rude things to me, but that's all right with it, you know, as you can live with it. And I'm sure you don't have lavatory walls covered in graffiti in Liverpool, so I'm sure you don't have that problem. But going back to the key question, you've mentioned it, Mike, is the second wave, yes or no. Now, the NHS is wedded to an epidemiology concept of the second wave hitting in September, October, and then winter pressures coming in later on in November, and a shutdown of the NHS, a complete lockdown again. That's the most pessimistic observation. You know, I can't say it won't happen, but I think all the data suggests it's not going to happen. But then I'm not an epidemiologist, so people say, well, what do you know about it, Karol? Well, I know that if we believe that model, and that's what local trusts are using in West London as well, that we're all, without the evidence, there's no published evidence. When you say, well, show me the data that's and they also, well, influenza of 1918, that was influenza, not corona, and it was 1918. You could measure nothing. You didn't even know it was a virus that caused it. No one knew what caused influenza in the Spanish flu epidemic. So totally different disease. Now, and pandemics do go in waves, but to go in waves, you read the second wave to be bigger, which is the NHS prediction of 5 times the mortality from the second wave. Imagine that. You'd have to reopen Nightingale hospitals. You'd have to convert back the outpatient clinics or what you have at the Royal Liverpool to actually take in people on ventilators and so on. So it would be a disaster. I think we've got to get going with cancer now and just obviously watch what's going on in terms of second wave, but we just got to get going. Whatever happens, we can treat a whole bunch of patients before that hits, if it's going to hit. I don't think it will, and we'll move smoothly into the winter. Sure, winter pressures are going to come. They're inevitable every year. And that's just a sign of lack of, I think, social service capacity rather than medical capacity. We deal with someone with an acute chest infection, 3 days of antibiotics and they're better. And then they can continue with oral antibiotics at home. But if there's no way you can send them because the social services can't cope or there's just no place for them, then we're stuck. And that problem is a very profound long-term problem in the UK. And it's not just the NHS, it's the social service as well, as you pointed out. So we can deal with it all. And I think maybe COVID has crystallized the way in which we think about these problems from now on.
Okay, brilliant, thank you. I was wondering if we could go to Mike. I will come back to you, Karol. We've got a few minutes before we go to questions. Mike, I'm particularly interested in the issue of the future of healthcare. So I'll come back to Karol to talk about what's most likely to happen. But, if you had a vision, as someone who's invested in Liverpool, from Liverpool, if you had a vision of how the future of healthcare was going to shape out, work out, what would that be really, given that we're now starting in a different place than where we were, say, 6 months ago?
Yeah, well, it's really interesting because I think COVID is a catalyst for change. And I think there's the opportunity to reform maybe some of the services within the NHS and look really more broadly at healthcare and say, what should the NHS be delivering? The NHS of Bevan's day is very different to today, very different challenges, a lot more technology. So how can the independent sector work more collaboratively with the NHS and maybe look at the model in Germany, which works very well, where there's a independent sector sat alongside a national service which works almost seamlessly. And those who can afford to take out private medical insurance should use the private medical insurance in the independent sector and get that access. And I'm not saying that we should have a two-tier service. What I am saying then is that private sector should also be used by NHS patients if there's a specialist service such as proton beam therapy is a great example. We have one national proton beam therapy centre in Manchester. Why should patients from Liverpool travel to Manchester for treatment, or even from Hull to Manchester for treatment, when there could be a local centre delivering that treatment? So it's about looking at what's available, where it's available, and working the public purse get the best value for that healthcare provision.
Okay, thank you. And if I come back to you, Karol, I think there's something about, so in the short term, you imagine that because we're good at dealing with a crisis, we get the various sectors working together and various providers perhaps addressing the backlog. But so Mike paints a kind of more optimistic, harmonious vision of the future. As someone who's straddled both, how do you really think that, if we look ahead sort of 5-10 years, how do you see how do you really see the future of healthcare in terms of us having the capacity to address this?
This is the future of healthcare, smartphone, and we're still not using it. It's a fantastic tool. It's underused all around the world, from poor countries to rich countries. Obviously, there's an age range of people. I'm at the upper limit of the age of people that can use one of these, and I'm probably using 10% of its function. But there's no doubt for healthcare, for prioritization, for dealing with a crisis such as the one we've got now, it's a very powerful tool in terms of information. If you have cancer, there are a limited number of apps you can actually load that are of any value to you. Sure, the charities have a few and they'll allow you to put in your appointments and share your blood counts and so on. But we're using just the top of the top tip of the iceberg there. There's a lot underneath we could be using. And in terms of workload, this crisis coming, I should be getting printouts every day of the number of biopsies in an area coming through the register. That would help us to plan both independent sector and NHS activity going forward. And I think that's what's coming, using information technology in a very different way. I think that's going to be the future of healthcare.
Let's just slightly probe on that, because I think there's, before we throw it open to questions, so just if Rory and Alex can be ready for that. It's that bit. So in our trust, so obviously it's a small specialist trust, but we've got a really big footprint. So we treat more people in North Wales than in Merseyside. But what you find is, certainly in Liverpool, is that things like telemedicine have really taken off. So how does that really work in cancer treatment? Is it really at the diagnosis stage that's the kind of vision you're painting?
You know, in medical school now, the students just rush to the scans. They don't bother examining patients. It's almost a lost art. I mean, when I was a medical student, we were taught by people that could really take clinical examination as an art form, and we were taught how to do it properly. I've forgotten it, and you don't need it now. You go to the scans to do it for you. That's a slight extreme. Now and again, you have to exactly touch the patient, and there is a sort of bond between the doctor and the patient involved in that touch. But when we look forward, a lot more. We've been so slow at using distance technology. I think, you know, at Rutherford, we've integrated all 4 centres, and images of radiotherapy, precision radiotherapy can be zoomed around the country, zoomed abroad, checked in America, coming back to us all within real time. I mean, it's just amazing to see. This wouldn't have been possible 5 years ago, far less now, and far less 10 years ago. And when I was taught radiotherapy, because I'm so old, there were no computers at all. It was all done by stencils and hand planning, and it was a real mess and not very accurate. So we've seen such huge improvements. And I think the next improvement is consumerism in healthcare, which is going to be dependent on having the right information. And so far, even if you have unlimited resources to get cancer treatment, it's pretty difficult without the knowledge to navigate Google to get the best possible care for you. It's difficult to check that you're getting the right care. So that's all going to come over the next 5 years. And I think people will be much more active consumers, not just patient. Even the name patient, it comes from Paschal and suffering, Easter, the Paschal candle and all that stuff. Patient is I'm sure will become a politically incorrect word, just as a lot of other words have become politically incorrect over the next few years. See if I'm right, Mike.
Okay. Now then, Mike, so I mean, I'll let you close down later on. So I'm just looking at the questions, and miraculously it's working. I think they've handed them over to me. So the first one is from Alec Barnes, and it says, what are the panel's thoughts on the news out of China around the resurgence of swine flu and how that should be viewed? I'm tempted to make Mike answer that, but I think Karol, you're probably best placed.
Yeah.
No, I did see. Okay, I did see it on the BBC website this morning. I get a briefing every day on COVID, and that was interesting. Swine. There were some lovely pictures of baby pigs in outside Beijing. Not harmed in any way, but with runny noses. I felt like sending them a box of paper handkerchiefs. But no, we don't know. We're all hypersensitive to any possible outbreak. I think more worrying is what's happening in Leicester and the reasons behind that, which have not been disclosed, and probably because nobody knows. I don't think there's any conspiracy going on. But the Chinese have been impeccable about the way they've, in a disciplined way, cracked down on second spikes. They're not second waves, they're spikes of activity as the virus peters out. So in Beijing, a wholesale food market, the RNA was detected on the chopping boards where the cooks were chopping up onions and things like that. And that was where the RNA was for the virus. And they shut it down. They only ended up with 260 cases over a 2-week period, and that's gone now. The Leicester thing, it's a sort of gentlemanly continuation of lockdown. No one's closing down Leicester, stopping all transport in and out of Leicester. That is the proper public health way to do something, but that would have too great political consequences. So I think we're going to get there. And I think the pigs, the nice pictures of the pigs on the BBC, but I don't think it's going to be a huge problem.
Okay, thank you. And there's one, I'll go on some others, but there's one specifically for Mike at the moment. It's saying, Mike, post-COVID, is there anything you would do differently in the design of your centres to take account of the patient journey and infection prevention?
Well, yeah, I mean, that's an interesting question, actually. And we have an excellent design team. And one of the early things that we did as a business is we created an organisation called Rutherford Estates. And what Rutherford Estates do is they ensure that we have continuity across all of our projects, whether it's in cancer or in the diagnostics business now. And we have a design team, quite excellent. They've designed all of our centres, and quite by chance, they'll tell me it was quite by design, I'm sure, but quite by chance, we have a number of entrances into our centres. So we built in a separate entrance for MRI and a separate entrance for the cancer business. And we've managed to use that quite well for COVID. So look, you know, there's always an after action review of whatever happens, and we're going through that process now. So there is the opportunity to work with the design team and the contractors, and we've got Interserve who've built two of our centres, one in Northumberland and one in Liverpool, and they've done an excellent job in there. We'd like to perhaps look at that with our design team and the contractors to say, is there anything that we do need to build in? But actually the resilience that we've had has been very good so far.
Brilliant, thank you. Now I've got one I'm going to throw out. I think you're going to have to handle this one as well, Mike. It says, I do like, you get a mixture of kind of generic and very, very specific. So the next one will be for Karol, but this is very much you. In terms of procurement, Mike, it says, you're not giving up at this point, good. In terms of procurement, is Rutherford Health and PP bound by NHS procurement, or do you have autonomy? And it's this from Stuart Fitzgerald, who's particularly saying, he works at Tucky Limited, and he's saying, who do you address comms to offer their revolutionary technology garments to protect IV chemo lines?
Yeah, so look, again, in this just as the COVID crisis happened, we had a planning meeting, and obviously PPE was a big issue. And, you know, we take great pride. We haven't furloughed any of our staff. We've taken nothing from the government, nothing from the system, nothing from the NHS. And we've been responsible for our own procurement. It'll be no surprise to people who may be on this webinar that know me. We've got an ex-military guy in charge of our procurement who's pretty hard-nosed, and he's termed the sledgehammer, and he's the guy who goes out and gets the good deals. And our procurement team have done a brilliant job. We've never been wanting on any of our PPE. All the staff felt safe, and we've got a nice backlog. So we do that independently. We're not tied to anybody, and if anybody wants to engage with us, they can either find us through the website, or Jane Slinger-Brennan, who's on this webinar, would be happy to put anybody in touch with the procurement team.
I'm more excited, Stuart. I think you've got to address your concerns to somebody called the sledgehammer. So that should
Good luck with that.
Yes, indeed. Yes. So, so Karol, there's one for you now. So it's from Dr. Andrew Rose, who's quite well known, certainly in business circles in Liverpool. So Karol mentioned a trend towards consumerism. How does he think this will impact upon the NHS?
Well, it has got more consumerist over the years, in all fairness. I mean, when I was a kid, There were no appointments in a general practice. You just pitched up and waited until you could be seen. And if you were unlucky, you never got seen. And that's the way it worked. There was no chance of seeing a nurse or anything else. There was no phone, there was no 111 to phone, there was nothing. And there was no choice. And I suppose if you want to have a consumerist healthcare system, the two elements you need to introduce are choice and competition. And that's very difficult within the NHS. It has been tried under a Labour government, ironically, and vestiges of it remain, but it's never really worked. Medicine is so funny in that it's never really been very consumerist. Even private sector medicine would prize itself. If you want an appointment to see a cardiologist in London this afternoon, you can find one on the web. There's no doubt you can do it. But if you want someone that you think of as being really a professional at the business, it's much more difficult. And access is difficult, even in the private sector. Have you got a GP's letter? Has he got a GP's letter? I've sent a patient of mine to see a haematologist on Friday privately. They're very affluent, paying her own way. And I've still got to get the letter to him by tomorrow. And this is bureaucracy thrown in a consumerist environment. So we've got to break all these barriers down and make people feel, even within the NHS, that they can make appointments. So I think that's part of the problem we're discussing now, why the cancer incidence has dropped precipitously, is that people don't feel empowered enough to overcome the hurdle of getting into the system. And I think that's the main message we have to get over to the consumers out there. Don't be afraid, the system is open, use it.
Okay, thank you. And I think so. There's a particular issue around. This is really aimed at Mike. There's a particular issue around. There's a particular issue around the public-private sector collaboration. So the one thing that most trusts have learned, Mike, is that in a situation when the supply chain breaks down, as it did at the beginning of this, you're down to what you've got locally. That's what you've got. And perhaps so things like there's abstract theories like, anchor institutions where, the NHS can be a driver for a local economy. We employ a lot of people, we can employ people locally. I wonder if there's any kind of lessons you think we're going to learn from that, really, because in a way, we did turn to our local basically our local community to help us through certainly the first 5 or 6 weeks. And I wonder if you think there's any legacy from that, or we'll just forget it, we'll just go back to outsourcing stuff from wherever we can get it cheapest across the world.
Yeah, well, look, I'm a great advocate for Great Britain and made in the UK. And I think, again, COVID is a catalyst for change. Brexit is a catalyst for change, where we will have to start manufacturing some of our own goods. And I think there are some real lessons identified here. Whether we learn from them is a different matter, but we've certainly identified a number of lessons. I've always been an advocate for bounding out from our centre. So we like to procure as much as we can locally. We obviously have national deals because we've got centres over a large geographical spread. But wherever we can, our centre managers are always encouraged to do business locally and support local businesses. And that includes clearly in terms of human resources, but also equipment coming into the centres. Because I think often we should rely on the local population that we serve.
Okay, that's brilliant. Okay, right. Well, I'm looking down and seeing that I think that's the end of the questions, so we may be able to give people 5 minutes back on their day. But I thought if you've got any closing thoughts, I thought we'd just poodle around. Obviously, I'll take chair's privilege and sum up at the end, and create the impression that I know what I'm talking about. But before that, I thought maybe, Karol, is there any kind of last thoughts before we finish the webinar?
So I guess if you go back to the wave analogy, we've seen the wave of COVID come and go. Looking out to see there isn't a second wave of COVID, but who knows, there might be. Difficult to imagine how that would work from an epidemiological viewpoint, but that we have to be prepared for it. more importantly out there is a wave of cancer that's definitely coming ashore. And when it's going to hit the shore, we don't know. I predict August, September, maybe even later than that by the time it gets through. How many people will be lost in that wave of cancer? It could be high. It could be, you know, we've lost 43,000 people so far with COVID, 44,000 people. The death rate now, as of last week, was back to normal, and it will go below normal for a bit now. So that's something to be thankful for. As we move forward, though, the more invidious death rate from cancer may go up. It all depends on what we do next and how the whole healthcare system, not just the NHS, but the whole system, public, private, third sector, mobilizes forces to deal with that wave of cancer coming to land. So that's what we've got to do, be prepared for it and move on it.
Okay, brilliant, thank you. And Mike, any last thoughts from you?
Yeah, I think, look, you know, for me, Rutherford is a huge success. We've done a great deal in such a short period of time. You know, often we can just focus on the scale of the investment we've raised or the technology we've put into place, but actually all of that is meaningless. What's really been successful about Rutherford is the people that made it happen, and that's an important factor. And then it's those same people who have been so resilient, the planning into not just COVID, but our resilience planning prior to COVID that we had to put in place during COVID has been really successful. So we've had 60% of the staff working from home, all of the clinical staff working operationally. As I said, only a short percentage of staff were shielding. So for me, it's about the people within the centres and within the business that make things happen, really important. And they're the people now who are preparing for July, August and September for this real surge. And that's where the real risk comes when things open up. What I would like to ask everybody on this call to do is advocate to family and friends if they have any signs and symptoms to make sure that they do go and get themselves checked, because there are people now who maybe could have been treated radically intent on cure, who may now be in a palliative pathway because they haven't had themselves diagnosed, and they're now living with cancer that could have a terminal impact on them.
Okay, brilliant, thank you.
Charlie Chester at the end there.
Yeah, no, I think it's but I think that's a really great way to end. And I would only sort of add that really, certainly the one thing that I would hate to lose from the whole COVID thing is that sense of community that's kind of really grown up, whether it's the local supermarket or wherever. There's been something about, okay, so we've had a few raves, and a few things like that, but actually the overall experience, it kind of, although it was a deeply unpleasant and unwanted pandemic, actually the kind of community side and the positive spirit and of human beings looking after each other has been something that sometimes you forget, really, and that's kind of a lovely kind of hopefully that'll be a legacy that stays with us for a while, and it creates those conditions where the kind of more optimistic visions that both yourself and Karol are sharing of the future can happen in. If we're in a kind of a period where we're kind of not kind of looking out for each other, and certainly as we go into a recession, we really do need to be employment, and certainly some of us are old enough to remember the early 90s, and it was deeply unpleasant. So that kind of that sense of hopelessness and things. So I think it's a kind of very positive way to end it, and to be clear that people do need to look. In the end, you have to look after your own and your loved one's health. So, and just before we do close, I'd really like to thank the three people in the background, because as you could probably see, two of the panelists, you could just drag them in from any point and they'd be able to talk. But so for thank Alex Clark and Rory Kane from Professional Liverpool and Jane Slinger-Brennan from Rutherford's for kind of doing all the work in the background. I think overall, I think it's been a really good webinar, and we've answered the questions. I thought it was very thoughtful, and hopefully, yes, and so thanks for a really good event, and hopefully you all have a really good day.